Welcome to Metta Health Talk. This is an urgent public health masterclass regarding the rapidly escalating meningococcal disease outbreak in Canterbury, Kent, UK. As of 5 p.m. March 17, 2026, the UK Health Security Agency, UKHSA, has confirmed 15 cases of invasive meningococcal disease, with laboratory verification of 4 meningococcal B infections. Tragically, this includes 2 confirmed deaths: a University of Kent student and a Year 13 pupil from Queen Elizabeth's Grammar School in Faversham. 11 other individuals remain hospitalized in critical condition. Epidemiological investigations have strongly linked multiple cases to visits at Club Chemistry nightclub in Canterbury between March 5 and 7, 2026. The UKHSA is urgently advising anyone who attended the club on those exact dates to immediately seek preventative antibiotic treatment at designated collection sites in Kent. Today, we will provide a complete clinical breakdown of meningococcal meningitis, from molecular pathogenesis to emergency treatment protocols, to empower you with life-saving knowledge during this unprecedented outbreak. Meningitis is not a single disease, it is a clinical syndrome characterized by inflammation of the meninges, the 3 protective membranes that envelop the brain and spinal cord. This inflammation can be triggered by multiple etiological agents: bacteria, viruses, fungi, or even parasites. However, the vast majority of life-threatening cases, especially during outbreaks like Canterbury's, are caused by bacterial pathogens, specifically Neisseria meningitidis, commonly known as meningococcus. Bacterial meningitis is extraordinarily aggressive because the bacteria rapidly multiply in the cerebrospinal fluid, CSF, a sterile environment with no natural immune defenses. Within hours, the infection progresses from a mild headache to complete neurological collapse. Viral meningitis, often caused by enteroviruses or herpes simplex, is generally self-limiting and resolves without antibiotics. Fungal meningitis, typically seen in immunocompromised patients, progresses much more slowly but carries a near 100% mortality rate if untreated. Today we focus exclusively on the hyperacute bacterial form driving the club chemistry outbreak. At the core of this Canterbury outbreak is Neisseria meningitidis, a gram-negative diplococcus bacterium that resides asymptomatically in the nasopharynx of 10 to 20% of healthy individuals. This bacterium has approximately 12 distinct serogroups, but serogroup B is responsible for the majority of invasive cases in the UK, particularly among adolescents and young adults aged 15 to 24. What makes meningococcus extraordinarily lethal is its polysaccharide capsule. This thick, slime-like capsule chemically camouflages the bacterium, allowing it to evade and destroy human phagocytes, white blood cells. Once inhaled via respiratory droplets from an infected person's cough, sneeze, or saliva, the bacteria adhere to the nasopharyngeal mucosa using specialized pili proteins. From this mucosal foothold, they rapidly invade the bloodstream, causing meningococcal septicemia. If unchecked, the bacteria cross the blood-brain barrier, triggering catastrophic meningeal inflammation and cerebral edema. Neisseria meningitidis is extraordinarily contagious within close-contact environments like nightclubs, universities, and shared living quarters. The primary mode of transmission is through direct or indirect contact with respiratory droplets and saliva from an infected carrier. Coughing, sneezing, kissing, sharing drinks or utensils at crowded venues like Club Chemistry dramatically facilitates person-to-person spread. The bacterium survives exceptionally well on dry surfaces for up to 72 hours, meaning shared cigarettes, vapes, or even nightclub door handles pose significant fomiti transmission risks. Carriers, individuals asymptomatically harboring the bacteria in their nasopharynx, represent 5 to 10% of the healthy population, but can unknowingly transmit during intimate or crowded social interactions. The Canterbury outbreak's link to March 5 to 7 club visits underscores how amplified close contact exposure in low-light, high-noise nightclub environments accelerates asymptomatic carriage to invasive disease. The absolute most critical clinical fact you must internalize is that bacterial meningitis has a razor-thin therapeutic window, typically 6 to 12 hours from symptom onset to irreversible neurological damage. Early symptoms mimic a severe flu: sudden, intense frontal headache, high fever exceeding 38.5 Celsius, profound muscle aches, myalgia, and extreme fatigue. However, the pathognomonic signs that scream meningitis are neck stiffness, neutral rigidity, and photophobia, extreme sensitivity to light. If you cannot comfortably touch your chin to your chest due to rigid neck muscles, or if bright light causes excruciating eye pain, seek emergency care immediately. In children and infants, symptoms manifest differently: high-pitched crying, bulging fontanelles, soft spots on the skull, and refusal to feed. Missing this early window allows the bacteria to fully invade the meninges, causing cerebral vasculitis and massive brain swelling. If untreated, meningococcal disease rapidly progresses to full-blown septic shock within 12 to 24 hours. The bacteria release massive amounts of endotoxin, lipopolysaccharide, triggering a cytokine storm that causes disseminated intravascular coagulation, DIC. This manifests as the classic petechial rash, tiny, non-blanching red or purple spots on the skin caused by capillary bleeding. The rash starts on the lower legs and rapidly spreads to the trunk, arms, and face. Critically, if you press a clear glass against the rash and the spots do not fade under pressure, this is pathognomonic for meningococcal sepsis. Concurrently, the meningeal inflammation causes massive cerebral edema, increasing intracranial pressure to lethal levels. Patients experience projectile vomiting, extreme confusion, delirium, seizures, and rapid descent into coma. Without immediate intravenous antibiotics and steroids, mortality exceeds 50% even in ICU settings. Rapid definitive diagnosis is the cornerstone of survival. The gold standard test is the lumbar puncture, spinal tap, which directly samples cerebrospinal fluid for gram staining, bacterial culture, PCR detection, and latex agglutination. Elevated white blood cell count greater than 1,000 cells per millimeter cubed, low glucose less than 40 mg per deciliter, and high protein greater than 100 mg per deciliter in CSF are pathognomonic. Blood cultures identify septicemia, while PCR rapidly detects meningococcal DNA even if antibiotics have already been administered. In outbreak scenarios like Canterbury, rapid antigen testing from throat swabs provides preliminary field diagnosis. Immediate empirical intravenous antibiotics are the absolute standard of care. Ceftriaxone 2 grams IV every 12 hours is the first-line agent, with vancomycin added if resistance is suspected. High-dose dexamethasone 0.15 mg per kilogram IV every 6 hours for 4 days dramatically reduces meningeal inflammation and prevents hearing loss. Supportive care includes mechanical ventilation for respiratory failure and vasopressors for septic shock. Post-exposure prophylaxis with a single 500 mg dose of oral ciprofloxacin or 3 days of rifampicin is mandatory for all close contacts of confirmed cases. Vaccines are the cornerstone. MenB, Bexsero for serogroup B, and MenACWY, Nimenrix for other groups. Herd immunity requires 80–90% vaccination coverage. If you visited Club Chemistry March 5 to 7, contact UKHSA sites immediately for free antibiotics. Monitor for symptoms 24/7. Vaccines recommended for all unvaccinated young adults. Meningitis kills in hours. Know the signs? Get vaccinated. Seek help immediately. Thank you for watching Metta Health Talk.